Hotbed Talk.
My name is Daniel Santamina. I'm an assistant professor at the University of Toronto and researcher at the Princess Margaret Cancer Centre. And
I'm Sandy Jack. You've already met me, but I'm Sandy Jack. I'm a professor of Prehabilitation Medicine at Southampton University and a consultant clinician scientist at University Hospital Southampton.
We're very excited to start another session on multimodal prehabilitation. At this time, I'd like to welcome the panelists to the stage for discussion. Dr. Chloe Grimmett. She is a National Institute of Health Research postdoctoral research fellow and senior research fellow for the Macmillan Survivorship Research Group at the University of Southampton. Chloe is a behavioral scientist with particular interest in the role of physical activity in cancer recovery and the development of interventions to support long-term engagement in physical activity. Chloe is the behavioral science lead for Wessex Fit for Surgery, or WestFit trial described yesterday, is a member of the National Cancer Research Institute Clinical Studies Lifestyle and Behavior Change Group, as well as the NIHR Cancer and Nutrition Collaborative.
It's my great pleasure to introduce both friend and colleague, Chelsia Gillis. She's a PhD candidate at University of Calgary. She's a registered dietitian and a Canadian Vanier scholar. She did her PhD candidacy in the University of Calgary under Franco Carli, who I call the godfather of prehab. And her research interests are in nutrition, and she's also got involved in prehab and enhanced recovery, and she's leading the first prehab program for colorectal surgery in Alberta.
It's my great pleasure to introduce Dr. David Yates. David is a consultant in anaesthesia and intensive care at York. His research interests include prehab for high-risk surgical patients, the use of CPET for risk stratification, optimizing hemodynamics using non-invasive cardiac output monitoring, and improving perioperative outcomes using protocolized care. And he's recently set up one of the UK's first perioperative medicine services at York.
My friend and colleague, Chris Snowden, he is a consultant anaesthetist at Freeman, Newcastle upon Tyne, and a senior lecturer at Newcastle University. His clinical job is a major surgery. He's extensive experience in developing preoperative assessment pathways and is a clinical lead. He incorporates cardiopulmonary exercise testing. He remains research active and has a research grant from the National Institute of Academic Anaesthetists, the Royal College of Anaesthetists and the British Journal of Anaesthesia to develop prehabilitation training in elderly surgical patients. Chris's overall work programme aims to promote the transformation of anaesthetists into a broader base of perioperative clinician. He also works part-time for NHS Improvement and NHS England, doing a fantastic and very important job of getting it right first time, where he's investigating clinical variants from all perioperative medicine services across the UK Trust. So, this is a question for Chelsia. In a prehab service with limited dedicated dietitian time, which screening tool do you think should be used to assess nutritional risk? And I ask you that question too.
There are several screening tools. So it's really going to depend on your patient population. And so in Canada, we use the Canadian malnutrition screening tool.
So if it's a cancer surgical population, perioperative medicine, what would you suggest?
You could use the MUST tool. You could use the Nutrition NRS 2002. I think the most important thing is that you have something in place.
Thank you.
We started doing NRS 2002 in York, and then realised that actually all the nurses were doing MUST on every patient that was admitted to hospital, and then it was just a standard of care. And I think there is stuff out there in the NHS that every patient admitted should have some form of nutritional assessment like that, a screening tool like that. So, and the MUST is so easy, isn't it, and quick to do. So,
the problem about it is that you often screen. It's like most of these things, you often screen but don't intervene. And that's one of the real problems. Yeah. So it's fine screening, you can screen for anything, but if you don't have the process in place to intervene, then what's the point in screening sometimes?
Exactly. You have to follow up.
Perhaps to follow up on that question, there was a specific interest in screening for self-management, and self-management to some extent is is something that applies to all of the behaviors. Chloe, would you mind speaking on whether or not there are any tools related to self-management in terms of screening a patient's capacity for that?
Yeah, it's a great question, and the simple answer is not specifically. The patient activation measure, which many of you may have heard of, is gaining traction. NHS England are really keen on that, and that gives a sense of kind of how involved and confident people feel in self-management. The questionnaire that we use to measure self-efficacy in the cohort studies that we're running is called the LORIG Self-Efficacy for Chronic Disease Self-Management, I think, and we've adapted it for cancer. But one of the pieces of work we're doing actually is trying to work out what kind of 5 or 6 questions you might include in something like an HNA to get a sense of how confident people feel to self-manage. So the PAM can be quite useful, and the LORIG as well, but I think we still need to do some work to maybe make those questionnaires even shorter.
And what would you do if you've established that someone has low self-efficacy?
Yeah.
What do you do next?
So again, excellent question, and there's not been enough studies to know really. It gives you an indication that people obviously need more support. So when you're thinking about the stratified follow-up, the best way to intervene is difficult to say, and also self-efficacy is a situation-specific thing. So people might have high confidence to do some parts of their care and low confidence to do others. So it's really important to explore what and where people need the most support. I think CNSs can often provide a huge amount of support, and also key workers are cropping up in quite a few trusts at the moment, and they can provide support as well.
Maybe it's because I'm Canadian or some other reason, but Sandy would like me to ask the question to Chris here. What advice would you give a patient about cannabis smoking cessation?
Not smoking cessation, that should be true. It's a very difficult question. I think there's really not enough evidence to say one way or another, and I haven't got any answers for that at all because I really have not been involved with that. So
they're normally smokers as well, aren't they? Obviously smoking tobacco as well.
I think the clustering,
we should be advising them to stop smoking anything.
So I
how
think
about vaping?
The whole thing relates around clustering of behaviours, and I think you probably pick up that very quickly, that smoking and alcohol usually goes together, weight and nutrition usually goes together, and lack of physical exercise. So it's how to break down those things, and cannabis may be just one thing that we add on to that behavioural cluster, and we have to start looking at these other drugs, etc., whatever we think about, and we have to start looking at how they cluster with the usual behaviours that we say, and I think it'll develop as it moves along. Marijuana is here, but it's not legal. It's legal in Amsterdam. It's legal in wherever, I think it is in Holland. So how that relates to the other type of behaviours, like Dave says, we have to start thinking about that. I don't think it's come to us majorly, but you just don't know.
So, Chelsea, what's the best method to detect sarcopenia, obesity in preoperative patients?
Oh gosh, that's tough. You can use several different methods. You can use bioelectrical impedance. You can use CT scans. In Canada, we use CT scans for the most part, and you can actually look at a CT scan really quickly once you are trained and figure out the prognostic value of it. But there's several different tools you can use, and in addition to looking at muscle, we also have to think about function, and that's the greater definition of sarcopenia involves looking at functional capacity as well. So that's something Franco and I are working on with CTs plus functional capacity and using that as a screening tool. But there's several different ways you can assess it.
Do you use hand grip at all, Chelsea?
We do have hand grip, yep.
And how does that relate to
outcomes?
Sarcopenia.
So if you have patients who have low muscle mass plus these other indicators, low strength, low functional capacity, it gives you a greater signal that they are truly sarcopenic or pre-sarcopenic. Mm. And we do use hand grip. We have hand grip, 6-minute walk test, 30-second sit to stand. We have several functional measures that we consider.
We'll direct this question perhaps to David, but this is Joanna's question. I think it's quite interesting. Is it worthwhile denying smokers and obese patients elective surgery? And is denial of a particular service like that an effective motivator?
Yeah, it's a good question, isn't it? So where I work up in Yorkshire, our local commissioning group, so who if you like purchase elective care from the hospital and hips and knee replacements, etc., have banned surgery on active smokers and people with a high BMI, and said you've got to lose 10% of your excess body weight or stop smoking or wait a year before you can have your surgery. And the guy who's in charge of commissioning actually lives in my village and was telling me that this came out in the press, that this was happening, and the head of the NHS, Simon Stevens, actually phoned him on Sunday morning and said, "Are you sure you want to do this? Maybe you want to have another think about that. Thank you very much," and put the phone down on him. And sure enough, they went back, they had their meeting, and they came back and said, "No, we want to do it." And my issue there is that it's being driven by lack of money. It is rationing. It's a way of rationing healthcare provision up there. And because they've brought in the BMI thing and the smoking thing. Now, the smoking thing, there's logic to it, isn't there? There is logic that if you're a smoker, you have worse outcomes, prevent surgery. I'm not saying it's right, but there is at least logic. My take on it is the BMI thing, there just isn't the logic there, because they've chosen a BMI threshold of 30. And in fact, if you look through the literature, there's no worse outcomes if you operate on someone with a BMI of 32. In fact, it's possibly even a little bit protective with the obesity paradox. So it's obviously a rationing thing rather than a health promotion thing that they've done it from. So I don't necessarily agree with it. I know that there's another question. Shall I move on to that other bit? Because there's other questions about, not operating on smokers at all if it's non-cancer surgery. And, if you speak to our plastic surgeons, they won't do breast implants and facelifts if you're a smoker. They just won't do it. It's not worth it. Insurance premiums are so high anyway that why would they risk an adverse perioperative outcome? Our foot surgeons are starting to say, I really don't want to do your bunions if you're a smoker, because obviously if you have a bad outcome with a foot, it's a bit of a disaster for patients. We're starting to see it happening. I'm not sure we're going about it the right way. I think a ban is probably not the right thing, but I think we do need to actually be a bit more forceful in the manner in which we are advising patients about the risks in the perioperative setting. So I'm not sure I agree with a ban, but I do think that there is an awful lot to do in between where we currently are and an outright ban.
So this is a question for Chloe. Can the questions used in psych interventions be open to interpretation and unclear to patients at points? Do you think data is impacted due to this?
Okay, that's a tricky one. I guess it depends what outcome measures you're talking about. I think oftentimes patients can find, they get a barrage of questionnaires and they can find they feel quite repetitive to them, although the psychologists are looking at different things. I think the thing we advise patients when they're doing these outcome measures is to go with your instinctive response. So normally the first thing you think of is right, and it's worth saying that some of them may feel repetitive, but they are kind of getting at slightly different things. So sometimes I think patients need a bit of reassurance that, we'll often see things scribble in the margins, like I've answered this one already or whatever. So sometimes just priming patients can help, I think.
Mm-hmm. Maybe the question directed to all the panelists is related to sleep disorders assessment and its impact on either perioperative outcome data or perhaps its relationship to the behaviors that, or the cessation of behaviors that you've described. these can all interrelate. I wonder if any of you can speak to the relationship and or how you assess for sleep disorders.
Again, I think it's around clustering, and there's a lot of data from, there's a paper in Australia, who are also looking at clustering of sleep disorders as well as smoking, alcohol, and I think it's something we've not thought about, but we certainly do need to think about, it's related also to physical activity, it's related to nutrition, so it's something that we need to look at. Yes, significant hypoxia, but most of our sleep apnea patients don't know. They're undiagnosed sleep apnea patients, and that's another group that I'd be particularly worried about. But if you're developing these screening processes, why not put in a sleep apnea screen as well? So I think we need to look at that as well.
I agree. I think it's lacking within perioperative medicine. We've got very minimal unpublished data showing that sleep hygiene was better in our exercise group, looking at activity monitoring to measure sleep hygiene, so quality and quantity of sleep. So I think it's a really important question.
Chloe, given that I'm giving a talk later on who delivers prehab, and this question here is going to help me out a little bit. So if not a psychologist, what personnel might be performing psychological coaching in a prehab program, and maybe thinking about the psychological programming as you described, maybe comprising of both psychological support as well as behavior change? Yeah,
I think everybody can to a certain extent. So empathetic listening. Even reception staff, and anybody that interacts with a patient, if they get consistent and supported messaging, that's really important. Obviously, the people with more complex needs need the specialist support. So we need more clinical psychologists, for example. There's no doubt about that. But, for example, specialist nurses can get particular training around this to help manage anxiety and distress. And again, the key workers can also potentially deliver some of the kind of lower need stuff, but we need more psychologists, we need more dietitians, we need more physios.
and to follow...
Is the answer not just who's trained properly to give
exactly.
it? That is really the answer. We trained our nurses to give brief behavioural intervention within 2 days, and they took it on board and started to deliver it. And we did some fidelity assessments of that as well. And so some were good, some were not so good. Yeah. So you have to go back to those people who can't continue to give that, and you need to retrain them. Whereas some people will get away with it within 2 days, and it's not a problem. So as long as there's some fidelity assessment along the way with regards to behaviour training, then I think it'll work, and anybody who's trained can give it. I don't say from the top level, so the sort of extensive psychological input, but even nurses are now being trained in CPD, and they've been able to give that sort of structure. So to me, we need more people to train, but I don't think people at a lower, what we say a lower level of behavioural teaching cannot give it. They can give it if they're trained properly.
That fidelity checking is really important. So particularly with something like healthy conversation skills, some people it just fits the way they speak to people anyway, and they take to it very naturally, whereas others have to completely relearn. And it's only through being observed and seeing examples of missed opportunities and maybe, not phrasing things quite the right way, people can develop the essays. Some people find it much harder than others, definitely.
If I may follow up on that question, has there been evidence, or in your practice, has there been a particular value to one behavior change strategy versus another, perhaps CBT or cognitive behavioral therapy versus motivational interviewing as 2 examples?
Yeah, so that's a really good question, and it's completely dependent on the type of behaviour you're talking about. So if we're talking about behaviour change for different things, so the behaviour change techniques that work for reducing or giving up something like smoking or alcohol are going to be very different to ones about sort of increasing physical activity, for example. So there's been a lot of work really led by someone called Susan Mickey at UCL. I don't know how many of you have heard of her. She came up with the behaviour change technique taxonomy, which is essentially a list of, I think it's 93 behaviour change techniques that are used, and encouraging people to identify those in their interventions so that we can synthesise the evidence more accurately to see which of these kind of active ingredients of the interventions work in which context. But yeah, that's work in progress. But I would encourage anyone that's writing a paper describing an intervention that's used any kind of behavioural modification to look at the behaviour change taxonomy and identify them in that way, because it makes synthesising the evidence much easier.
Chelsia, does immunonutrition work?
Don't ask me that question.
Well, it's a really important question, and it was a question that we had fun and games with the guidance.
Yes,
so I think it is really important, even just a comment or an opinion.
Okay, my opinion is that I'm not convinced. I don't know if it works. I don't know if it doesn't work. I'm not convinced as of yet. And that's largely because of the meta-analyses that I've seen compare immunonutrition to nothing. And nutrition is going to be better than nothing.
Okay, so be controversial. Could it do harm?
There have been studies in critical care, but in surgery I haven't seen any of those studies.
Thank you.
Maybe this is to follow up on the nutrition and behavior change theme, but are there sensitive approaches to addressing maybe weight loss, physical activity, and diet, perhaps, that you might recommend? And if you have an obese patient, or you have a patient who clearly needs to lose a few pounds, is there something that you might suggest to be sensitive?
Yeah, I mean, that's really tricky, and there's been quite a lot of work done, particularly speaking to GPs, general practitioners, about how to go about this. And it can be affected by your own weight status as well. So practitioners who are themselves overweight don't necessarily know how best to talk about it. People who aren't overweight have kind of the opposite problem of patients sitting there thinking, well, it's all right for you, you don't have an issue. So it's really difficult. There is training out there to talk about these issues, both in adults but also in children. But I think use of language has been shown to be really important. So we know that patients or the people in the general population tend not to like the words obesity and prefer to speak about weight or BMI. I think ultimately it's about trying to be as sensitive and non-judgmental as possible, which is. I
think that it depends on the rapport you have with people, and that I usually go about saying things like, understanding what the root cause is, and so for a lot of people it's emotional eating, and to validate that there's a reason that serves a purpose in your life. And that I understand, and then to move towards other ways of dealing with that instead.
Yeah, and people who, people often have tried loads of different ways to lose weight. So opening up a conversation with, how are you feeling about your weight? Would you like to talk about anything that you've tried in the past, and acknowledge how difficult it is, and some GPs are referring into things like Weight Watchers. There is evidence that those kind of things work. So, opening those channels could be really important as well. If patients see that their GP is sending them to that for free, they kind of think, well, if the NHS are doing that, it must have some evidence. So that can be quite powerful as well.
Yeah, we were going to throw it out to the audience, yes. So,
as a person who looks after people with obesity, I think saying obese patients, no one in the audience here would say looking after a cancerous patient. So I think our language, as you said, is very important. And also saying to them, you have obesity, you're not an obese person, is a very big start in terms of them feeling more comfortable.
Absolutely. So it's patients with cancer, not a cancer patient. I couldn't agree more. Excellent question. Any more questions from the audience?
Sorry, can I just add the last bit of that? We can talk about obesity or BMI or whatever, but how can we harness the golden moment, which is surgery? So you can talk about obesity and put it into whatever language you want, but is there a way of putting that into the context of surgery, which is what we're trying to do?
What I try to do is just say body composition. So we usually say things like, we're going to build up your muscle, start with the positives, and reduce some fat.
But the point is, why? So the question then would come back from, as me as a patient, was, okay, I'm overweight, but why do I need to do that? And I think if we don't start thinking about that, putting it into the context of surgery, which is what we're trying to do, then we lose the hook a little bit.
Yeah. I find that almost every patient I've seen who is obese, their surgeon has already told them, you need to lose weight. So when they see me, I've actually had patients who went on drastic diets that were verging on malnutrition because they were so scared that they were overweight before their surgery. So I think that they do take it pretty seriously when they hear it from their surgeon, in my experience. And then it's to manage the weight loss in an ideal way, preparing for surgery.
Any last questions? The last question to the audience. Any? Oh, thank you.
If I can just add to that last comment, I think it's important not to focus on the fat mass or the lean mass. They are just markers of a metabolic state. It's the metabolic state we're trying to improve. And we know from if you want to use I don't like the term, but the fit but fat, or the fat and fit story, it is possible for people who are heavier to have good metabolic control. If we introduce in a very short period of time a diet and activity program, we shouldn't be expecting them in that prehabilitation period necessarily to lose weight, especially or get rid of fat, which has taken them many, many years or sometimes decades to accumulate. What we want to do is get them metabolically fit. And if we can focus on improving their metabolic control rather than their composition over that prehab period. After the interventions, clearly we want to mitigate further loss of lean. But it's more about improving metabolic control. And I think that's the theme we've got to go back to, rather than you've got to lose fat, it's just too complex.
More positive message.
It's a very positive message.
I'm going to close the session.
Can I just make one quick shout?
I forgot to make
Steve, quick.
I'm going to invite Chelsia.
No, go ahead.
Well, we just wanted to say there's a lot of interest in nutrition. If there are dietitians, nutritionists, and those specifically interested in nutrition, we're trying to get a group together. We're going to be in the Stevenson room, which I believe is next door. Just checking. I believe it's next door. Just to briefly meet for 10 minutes before the rest of the day, just so we can make contact with each other.
Please join me in thanking our panelists for the session.
Lee Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.